Hey there, curious minds. Welcome back to the Deep Dive, where we sift through the sources, extract those vital nuggets of knowledge, and make complex topics click. Today, we're diving deep into something truly fundamental: cell injury and cell death. Mm, This isn't just another biology lesson, it's really the bedrock for understanding every disease that affects the human body, from a minor cut to a major illness.
That's absolutely right. For you, especially those of you just starting your medical path, think of this deep dive as your essential roadmap. Our mission today is to give you a clear, memorable framework, maybe with some handy anchors, metaphors, and some key questions to help you understand, retain, and most importantly, recall these vital concepts when it matters most. In the clinic.
So, if you're ready to peer into the microscopic world, maybe grab your mental lab coat, because we're about to put the cell under the microscope and uncover its deepest vulnerabilities. Okay, let's start by setting the scene a bit. As future clinicians, you'll meet patients with symptoms all the time. But the real challenge is figuring out why those symptoms are there. How do you actually go from what you see or hear to a concrete diagnosis?
Exactly. Your anatomy and physiology courses are brilliant for telling you where a symptom has arisen, which organ, which system. But this deep dive, focusing on the mechanisms of disease, this will help you determine what the underlying disease process actually is. It's all about combining your clinical skills, the history, the exam, the investigations, to pinpoint the source and the specific cause.
It's like going from a blurry photograph to a high-definition image, right? Getting right down to the cellular level. And to truly visualize this, we use three distinct lenses when we're looking at cell injury.
Precisely. Yeah, three levels. We assess cell injury at the gross level, that's with the naked eye, just looking at the organ's appearance. Then we move to the light microscope for the microscopic cellular and tissue changes. And finally, for the most detailed view, the electron microscope. That reveals ultrafructural features, like changes to the tiny organelles inside the cell. Each perspective gives you a really critical piece of the diagnostic puzzle.
Okay, let's unpack this. Cells are incredibly resilient, they put up with a lot. But there's a limit. So what kinds of insults can push a cell past its breaking point? We've identified the big nine major categories of cell injury. Now, the list is pretty extensive, but having this kind of mental framework helps you rapidly categorize a patient's problem. It's almost like a diagnostic shortcut. Let's dive into some of the most critical players on that list.
Okay. And topping that list, arguably the most common and profoundly impactful cause of cell injury and death is hypoxia, which is, a fancy word for oxygen deprivation. But the key insight here isn't just that oxygen matters, it's recognizing its diverse forms, because each form points to a different clinical picture. To help you grasp this, think HIH. First, hypoxemic hypoxia. This is when there's low arterial oxygen content, often due to issues like, say, cardiorespiratory failure. The blood simply isn't carrying enough oxygen. Then ischemic hypoxia. Here, the blood supply itself is interrupted. Think a blocked artery. This is often more severe because it cuts off all metabolic substrates, not just oxygen, glucose, everything. Then anemic hypoxia. This means a decreased oxygen carrying capacity in the blood. You see this in conditions like anemia or carbon monoxide poisoning, where red blood cells just can't do their job efficiently. And finally, histoacidic hypoxia. In this scenario, the cells have oxygen, but they're unable to actually use it. This happens when the enzymes vital for oxidative phosphorylation are disabled. Think cyanide poisoning or maybe a paracetamol overdose.
Wow, so with this silent thief hypoxia at work, what exactly happens inside a cell? Does it always lead to the cell dying? Or can cells actually bounce back from the brink? It's a good question to keep in mind, right? We'll circle back to this crucial point in a bit.
Indeed, that's the core question of reversibility. Absolutely key. And beyond hypoxia, the big nine also includes a whole host of other things. Physical agents, mechanical trauma, extreme temperatures like burns or frostbite, electric shock, radiation, even sudden changes in atmospheric pressure, chemical agents and drugs. This includes potent poisons like cyanide or arsenic, but also everyday pollutants. Even high concentrations of normally harmless stuff like oxygen or glucose can be toxic. And of course, both recreational drugs and therapeutic medications. Infections, a huge range of microorganisms, from viruses to bacteria, fungi, parasites, they can all directly injure cells. Neoplasia, that's tumors, whether benign or malignant. They cause damage through local pressure, invasion, tissue destruction, or even systemic effects like fatigue and weight loss, metabolic or biochemical derangements. This covers things like low blood sugar, hypoglycemia, electrolyte imbalances like edema or abnormal sodium or calcium levels, or the buildup of waste products like urea and kidney failure, or toxic intermediates in genetic conditions like PKU, immune-mediated processes. This is when the body's immune system messes up. It might turn against itself, like in autoimmune diseases, or it might overreact, as in hypersensitivity reactions like asthma or anaphylaxis. Nutritional imbalance. And this goes both ways. Not just dietary insufficiency like malnutrition, but also dietary excess, contributing to things like obesity, diabetes, atherosclerosis, and finally, genetic abnormalities. These are problems right down at the chromosome and gene level, which can lead to missing proteins or the buildup of toxic substances from birth.
Phew. That truly highlights just how many ways a cell's delicate balance can be disrupted. It makes you realize how many battlefronts a cell faces every single day. Okay, here's where it gets really interesting, I think. Let's think of a cell like a carefully constructed building. If it's going to suffer damage, where are the critical points of failure? What are those sort of four pillars that keep it standing? Where is the cell most vulnerable?
That's an excellent analogy, yeah. Regardless of the specific cause of injury, cells often have four main targets where damage tends to concentrate. Number one, the plasma membrane. This is basically the skin of the cell, absolutely vital for maintaining its internal environment. And this also includes the membranes that compartmentalize organelles, like the lysosomes. Number two, the nucleus. This contains the cell's genetic blueprint, its DNA. Damage here can have really profound long-term consequences. Number three, structural proteins and enzymes. These are the building blocks and the machinery that perform all the cell's metabolic processes. If they get damaged, things grind to a halt. And number four, mitochondria. The famous powerhouses where ATP production happens, mainly through that very efficient oxygen-dependent process, oxidative phosphorylation.
Indeed, the mitochondria are a crucial fourth pillar. They're the cell's powerhouses, and their primary job is generating ATP, the energy currency of life. So when these powerhouses are threatened, say by hypoxia, what happens to that vital energy supply?
Right. ATP, adenosine triphosphate, it's absolutely critical. Now, cells can generate a little bit of ATP less efficiently through glycolysis, even without oxygen. But the vast majority is made in the mitochondria using oxygen. So when oxygen is deprived, as in hypoxia, ATP production just plummets.
Okay, now let's circle back to our earlier question about hypoxia and whether a cell can recover. This drop in ATP really marks the cell's tipping point, doesn't it? Where it goes from just being injured to being terminally ill.
Precisely. Yeah, that's the turning point. Initially, when oxygen is deprived, the cell experiences a cascade of events, and many of these are actually still reversible if oxygen returns quickly enough. First, the NAP plus K plus plasma membrane pump, which absolutely needs ATP, starts to fail. This causes sodium to rush into the cell, and water follows osmotically. This leads to the cell and its organelles starting to swell. The technical term for this is anaerosis. Then the cell tries to compensate. It switches over to glycolysis to make some ATP anaerobically, but this produces lactic acid, which drops the intracellular pH. This low pH, this acidity, can cause chromatin clumping within the nucleus and also affect enzyme activity. Another thing, ribosomes detach from the endoplasmic reticulum. This disrupts protein synthesis, basically because energy is needed to keep them attached and working properly.
Okay, so that's the reversible stage. But if that hypoxia or whatever the injury is just keeps going, the damage becomes irreversible, right? When does that power outage become a permanent system failure?
Yes, it does. The crucial event, the point of no return marking irreversible injury, is a profound, irreversible disruption of membrane integrity, especially the plasma membrane and lysosomal membranes. This leads to a massive influx of calcium ions, Ca2+, into the cytoplasm. Normally, calcium is kept at incredibly low levels inside the cell, but these high cytoplasmic levels activate a whole destructive cascade of enzymes. You get ATPases activated, which deplete ATP even further. Phospholipases start to degrade cell membranes, chewing them up. Proteases break down essential membrane proteins and cytoskeletal components, undermining the cell structure. And endonucleases damage the DNA, leading to nuclear chromatin clumping and eventually fragmentation. Plus, when those lysosomal membranes are compromised, their powerful digestive enzymes leak out and start destroying the cell from within. It's pretty catastrophic.
What's truly insightful here, I think, is that while calcium is rushing in, other substances are leaking out from these irreversibly damaged cells. And these are like cellular smoke signals, aren't they? Things we can actually detect in the blood, giving us crucial clues about where the damage is occurring in the body.
Absolutely. And sometimes, in a cruel twist, a well-intentioned intervention can actually make things worse. Ischemia reperfusion injury is a classic example. This is where restoring blood flow to an ischemic but not yet dead tissue can paradoxically cause more damage. This is often due to a sudden burst of oxygen-free radicals when oxygen returns, plus an influx of inflammatory cells like neutrophils and activation of the complement system. It's a really critical challenge we face constantly in clinical practice, trying to balance saving tissue with avoiding reperfusion injury.
We just mentioned free radicals and reperfusion injury. Now, these sound a bit villainous, don't they? But I hear they're not always the bad guys.
That's a great observation. Yeah, they have a bit of a bad rap. Free radicals are technically reactive oxygen species, or ROS. They're molecules with an unpaired electron, which makes them highly unstable and, well, reactive. The most biologically significant ones include OH, hydroxyl, O2 superoxide, and H2O2, hydrogen peroxide. And it's worth remembering that the hydroxyl radical OH is often considered the most dangerous because it's just so incredibly reactive. They attack lipids in cell membranes, causing lipid peroxidation, which causes significant damage. They can also damage proteins, carbohydrates, and even DNA, leading to mutations.
So it sounds like molecular chaos inside the cell.
It can be, yes, but the body actually uses them for good things too. Phagocytes, for instance, use them deliberately to kill bacteria, and they play roles in normal cell signaling. The real problem arises with oxidative stress. That's an imbalance where free radical production overwhelms the body's natural defense systems. Luckily, we have these antioxidant systems. They include enzymes like superoxide dismutase, SOD, catalases, and peroxidases. These basically convert harmful free radicals into less toxic forms. Free radical scavengers, things like vitamins A, C, and E, and glutathione, these directly neutralize the free radicals. And storage proteins like transferrin and ceruloplasmin, they sequester transition metals like iron and copper, which can otherwise catalyze the formation of free radicals.
It's like the cell has its own internal fire brigade and repair crew all rolled into one. And speaking of repair, let's touch on heat shock proteins, or HSPs.
Yes, HSPs are crucial. They're also sometimes called chaperonins, and they act like molecular protein mechanics. When cells are stressed or injured, proteins can misfold or denature. HSPs help mend these damaged proteins, preventing them from clumping together and guiding them back to their correct functional shape. And if a protein is damaged beyond repair, HSPs, working with systems like ubiquitin, can tag it for degradation, basically clearing out the irreparable damage and ensuring cell viability by maintaining protein quality control.
Okay, now for another thought experiment. If you imagine a cell that's destined to die, does it always go out with a big messy bang, a big inflammatory scene, or can it sometimes just sort of leave the stage in a far more orderly, almost imperceptible fashion?
That's the fundamental distinction in cell death, and it's a really critical concept to get straight. We essentially have two main paths a cell can take when it dies: necrosis and the apoptosis. Let's start with necrosis, the messy demolition. Now, necrosis is always a pathological process. It typically results from severe, irreversible injury like ischemia or exposure to toxins. It's characterized by two main events happening inside the cell: the denaturation of intracellular proteins and the enzymatic digestion of the dying cell. This digestion comes from the cell's own lysosomes leaking and also from powerful enzymes released by inflammatory white blood cells, the leukocytes, that rush to the scene. Crucially, this messy demolition always triggers an inflammatory response in the surrounding tissue, and it takes several hours before you can actually see the changes clearly under a microscope.
Right, and within necrosis, we see different patterns, don't we? Which are really vital clues to the underlying cause. Let's remember the five five types of necrosis, though maybe we focus on the main ones.
That's a great mnemonic, yeah. Let's focus on the big three clinically. First, coagulative necrosis. This is the most common form. It typically occurs in solid organs like the heart, spleen, or kidney when blood flow is suddenly cut off, ischemia. What happens is the proteins denature, but the basic cell outline is preserved for a while, forming ghost cells. Grossly, it creates a firm, often pale, wedge-shaped area of dead tissue. This is classic in a myocardial infarction, a heart attack. Second, liquefactive necrosis. This is seen most commonly in the brain following a stroke, or in infections that form abscesses anywhere in the body. Here, enzymes rapidly degrade the dead tissue, completely liquefying it. This often results in creamy yellow pus, which is basically just dead leukocytes and cellular debris. Third, caseous necrosis. From the Latin for cheese, this type has a characteristic cheese-like gross appearance, soft, white, and granular. Microscopically, it's just amorphous debris. It's the hallmark of granulomatous inflammation, and the most common cause by far is tuberculosis.
Okay, those are the main types. But what's also important to clarify are terms like infarction and gangrene, because they're often confused with types of necrosis, but they aren't, are they?
You've hit on a key point there. No, they're not types of necrosis themselves. They're more like descriptions or causes related to necrosis. Infarction simply refers to an area of necrosis caused specifically by ischemia, that is, reduced blood supply. Infarcts can be white or pale, typically in solid organs with single-end arteries like the heart or kidney, or they can be red, meaning hemorrhagic. These occur in organs with a dual blood supply or looser tissues like the lung or intestines, where blood can seep into the dead area. Gangrene, on the other hand, is really a clinical term used to describe visible necrosis, usually of a limb or digit, often involving superimposed bacterial infection. It's further categorized based on its appearance. Dry gangrene. This is basically coagulative necrosis that's been modified by exposure to air. The tissue dries out and shrivels, becoming dark and mummified. Think of frostbitten toes that turn black. Wet gangrene. This happens when the necrotic tissue gets infected by bacteria, leading to liquefactive necrosis dominating. The area becomes swollen, foul-smelling, and filled with pus. This carries a high risk of spreading infection or septicemia. And there's also gas gangrene. This is a specific dangerous type of wet gangrene caused by gas-forming bacteria, often Clostridium species. You can actually feel or sometimes see bubbles of gas within the dead tissue, typically seen in deep contaminated wounds like crush injuries. Okay, so that's the messy side. Now, in stark contrast to that demolition, we have apoptosis, the tidy departure. This is an energy-dependent, highly programmed form of cell death. The word itself actually comes from Greek, meaning falling off, like autumn leaves falling from a tree. Very different vibe.
So it's a much more controlled process then, almost like a cell's pre-planned clean exit strategy. What sets it apart most dramatically from necrosis in terms of what you'd see?
Absolutely. It's highly regulated. Apoptosis involves a characteristic non-random cleavage of DNA into specific fragments. Morphologically, the key features are cell shrinkage, the opposite of the swelling seen in necrosis and condensation of chromatin in the nucleus. And crucially, apoptosis does not result in an inflammatory response. The dying cell basically packages itself up neatly. It typically affects single cells or small clusters, not large areas like necrosis often does. Think of it like a sculptor carefully chipping away unwanted bits from a block of marble to define a shape. That's what happens during embryogenesis when the webbing between our fingers and toes is removed. That's apoptosis in action.
So it can be a completely normal physiological process, not always a sign of disease or injury.
Exactly. Physiological apoptosis is absolutely vital for many normal processes, like embryogenesis and fetal development, for sculpting tissues and organs correctly, for hormone-dependent involution, like the cyclical shedding of the endometrium during menstruation, or breast tissue regression after weaning, for maintaining regulation of cell populations in tissues that constantly renew, like our immune system or the lining of our intestines, and simply for the removal of cells that have served their function and are no longer needed, such as neutrophils after they've dealt with an infection, or lymphocytes that could react against self. However, apoptosis can also be pathological. Dysregulation of apoptosis plays a role in many diseases. In neoplasia, or cancer, apoptosis often fails to occur normally, which allows mutated cells to survive and proliferate uncontrollably. In autoimmune conditions, lymphocytes that are programmed to attack the body's own tissues sometimes fail to undergo apoptosis as they should. And in AIDS, for example, HIV proteins can actually trigger apoptosis in uninfected T helper lymphocytes, contributing significantly to the immunodepletion seen in the disease.
So how does the cell actually carry out this incredibly precise suicide program? What's the internal machinery?
The central executioners are a family of enzymes called caspases. They are cysteine-dependent aspartate-directed proteases. Think of them as molecular scissors. They exist as inactive precursors or procaspases, and they get activated in a cascade by two main pathways. First, the extrinsic pathway. This is triggered by signals from outside the cell. Death receptors on the cell surface, like TNF receptor or FAS, bind to their specific ligands. This binding activates initiator caspases, like caspase 8. Second, the intrinsic or mitochondrial pathway. This is triggered by signals from inside the cell, like DNA damage, accumulation of misfolded proteins, or withdrawal of essential growth factors. These stresses lead to increased mitochondrial permeability. Molecules like cytochrome C leak out of the mitochondria into the cytoplasm. There, cytochrome C binds with other proteins, like APAF1, and an initiator caspase, caspase 9, to form a complex called the apoptosis, which activates caspase 9. Both pathways, extrinsic and intrinsic, ultimately converge on the activation of executioner caspases, most notably caspase 3. Activated caspase 3 then goes on to cleave numerous cellular proteins, leading to the characteristic features: chromatin condensation, nuclear fragmentation, breakdown of the cytoskeleton, and finally the cell breaks down into membrane-bound fragments called apoptotic bodies. These contain bits of cytoplasm and nucleus. Crucially, the membrane stays intact. These apoptotic bodies are then rapidly phagocytosed, basically eaten up by macrophages or even neighboring cells, leaving no debris and, importantly, no inflammatory trace. A very tidy exit.
So to finally answer our question from earlier, cells can definitely go out in two very different ways. You've got the messy demolition of necrosis, always pathological, always inflammatory. And then you have the tidy programmed departure of apoptosis, which can be normal or pathological, but is crucially non-inflammatory. Understanding this fundamental distinction really is key to diagnosing a huge range of conditions.
You've summarized it perfectly. Yeah, the key differences really boil down to those observable features. Cell size, swelling in necrosis versus shrinkage in apoptosis.
Yeah.
Nuclear changes, chaotic breakdown like pinosis, karyohexis, karyolysis in necrosis versus orderly fragmentation in apoptosis. Membrane integrity, disrupted and leaky in necrosis, intact in apoptosis. Cellular contents leaking out and causing inflammation in necrosis contained within apoptotic bodies in apoptosis. And the big one, the presence or absence of adjacent inflammation, frequent and defining in necrosis, absent apoptosis.
Okay, let's jump back slightly. Earlier, you mentioned that irreversibly injured cells leak substances, acting like those cellular smoke signals. How does this actually help us in a clinical setting? What can we measure?
Right, those leaked molecules. They can indeed cause local inflammation or even systemic toxic effects if the cell death is widespread. But, very importantly for diagnosis, their presence in high concentrations in the blood can be a powerful tool. We can measure them. Take potassium. Potassium is usually kept at very high concentrations inside cells. When lots of cells die suddenly, they release this potassium into the bloodstream. This can be like a potassium bomb, causing hyperkalemia, which can lead to severe problems like cardiac arrhythmias or even cardiac arrest. You see this risk in large myocardial infarctions, severe burns, or something called tumor lysis syndrome. Then enzymes. Many enzymes are relatively specific to certain organs. When those organ cells die, the enzymes leak out. Measuring them in the blood is crucial. For example, elevated transaminases like ALT and AST point strongly towards liver injury, while specific cardiac enzymes like troponins are highly sensitive and specific markers for myocardial infarction. These not only signal damage but can also help estimate its extent and even the timing of the event. And another one is myoglobin. This protein is released from dead heart muscle, myocardium, and also from damaged skeletal muscle. In conditions like rhabdomyolysis, which is severe muscle breakdown, maybe from trauma, extreme exercise, certain drugs, or crush injuries, large amounts of myoglobin are released. This myoglobin can actually damage the kidneys, leading to acute renal failure and characteristic dark brown urine.
It's incredible how the body leaves these subtle yet detectable clues in the bloodstream. Okay, so what about when a cell is under stress but maybe not dead yet, not irreversibly injured? You mentioned it can start to accumulate clutter internally. Sometimes this is reversible, but sometimes it can lead to severe consequences too.
Absolutely. These abnormal intercellular accumulations happen when metabolic processes are deranged, but the cell isn't necessarily dying, or at least not yet. The accumulated substance can come from the cell's own abnormal metabolism. It can be synthesized elsewhere and transported in, or it might even be something from the environment the cell can't deal with. They fall into a few key groups. First, water and electrolytes. We already touched on this with reversible injury. It's seen as hydropic swelling or cellular edema. This osmotic disturbance causes cells to enlarge with water. It's a sign of severe cellular distress. And in places like the brain, where there's no room to expand within the skull, this swelling can be particularly dangerous, causing increased intracranial pressure. Second, lipids. This is a big category. Steatosis, or fatty change. This is the accumulation of triglycerides, most famously seen in the liver due to things like chronic alcohol abuse, diabetes, or obesity. The liver can become enlarged, heavy, and distinctly yellow. Think of foie gras that's basically induced steatosis in ducks or geese. It's often reversible if the underlying cause is removed, cholesterol. Cholesterol and its esters are insoluble. They tend to accumulate in smooth muscle cells and macrophages, turning them into foam cells. You see these prominently in atherosclerotic plaques, lining arteries. They can also form visible deposits called xanthomas in the skin, or tendons in people with genetic hyperlipidemias. Third, proteins. Sometimes abnormal proteins accumulate. These often appear as eosinophilic, pink staining droplets or aggregates within the cytoplasm. Classic examples include Mallory-Heiling bodies, which are tangled intermediate filaments seen in liver cells in alcoholic liver disease, or abnormal alpha-1 antitrypsin globules that accumulate in liver cells in a genetic deficiency, leading to both lung and liver disease because the protein can't be secreted properly. Fourth, pigments. These are basically colored substances, and they can be either exogenous from outside the body or endogenous produced within the body. Exogenous pigments. The most common is carbon or coal dust inhaled from polluted air or smoking. Macrophages in the lungs gobble this up, leading to anthracosis, blackening of the lungs, or, in heavy exposure, coal workers' pneumoconiosis. Type 2 ink is another example. Macrophages engulf the pigment and hold on to it pretty much indefinitely. Endogenous pigments, these are produced within the body. Lipofuscin, often called the age pigment or wear and tear pigment. It's a yellow-brown granular material, basically polymers of oxidized lipids and proteins that result from past free radical injury. It accumulates over time in long-lived cells like neurons and heart muscle cells. It doesn't seem to harm the cell, but it tells you the cell has been around and seen some action. Hemosiderin. This is an iron storage molecule, appearing as golden yellow to brown granules. It's derived from the breakdown of hemoglobin. Small amounts are normal, but it accumulates excessively in conditions of iron overload. This can be local, like the brownish discoloration you see in an old bruise, or systemic, known as hemosiderosis. A key example is hereditary hemochromatosis, a genetic disorder causing massive iron accumulation, historically called bronze diabetes because of the skin discoloration and pancreatic damage it causes. And finally, bilirubin. This is a bright yellow bile pigment derived from the heme part of hemoglobin breakdown.
Normally, it's processed by the liver and excreted in bile. But high levels in the blood may be due to excessive red cell breakdown, hemolysis, liver disease, or bile duct obstruction, cause jaundice, that characteristic yellow discoloration of the skin and the whites of the eyes. Sclerae. And there's one more important abnormal accumulation to mention: calcium salts. This leads to pathological calcification. We categorize this into two main types, based on calcium levels in the blood. First, dystrophic calcification. This is the more common form. It occurs in areas of dying, damaged, or necrotic tissue, even when the patient's plasma calcium levels are completely normal. You see it commonly in aging or damaged heart valves or within atherosclerotic plaques and arteries. The local tissue changes, maybe altered pH or exposed lipids, favored the deposition of calcium crystals. Interestingly, the pulmonary valve rarely calcifies compared to the aortic valve, maybe because the blood around it is slightly more acidic. Second, metastatic calcification. This is different. It's systemic and occurs when there is hypercalcemia, meaning abnormally high levels of calcium circulating in the blood.
In this case, the calcium salts deposit in normal, otherwise healthy tissues throughout the body, particularly in places like the stomach lining, lungs, kidneys, and blood vessels. The causes of hypercalcemia include things like hyperparathyroidism, certain malignant tumors that secrete parathyroid hormone-related protein, vitamin D intoxication, or even prolonged immobilization leading to bone resorption.
Okay, that covers the main accumulations. Now, if we connect all this cellular detail back to the bigger picture, it's really fascinating how these precise mechanisms manifest in broader clinical scenarios we all recognize. Consider something as universal as cellular aging.
Right. Cellular aging is complex, but a key aspect is the gradual accumulation of damage to DNA and other cellular components over time. Also, most normal cells have a limited capacity to replicate. This is called replicative senescence. It's intrinsically linked to the shortening of telomeres, which are protective caps at the ends of our chromosomes. With each cell division, these telomeres get a little shorter. Eventually, they become critically short, signaling the cell to stop dividing. Now, germ cells and stem cells have an enzyme called telomerase, which can rebuild and maintain telomere length, allowing them to replicate potentially indefinitely. And it turns out that many cancer cells manage to reactivate telomerase, which contributes to their uncontrolled proliferation.
That's fascinating. And another common culprit we see clinically with widespread cellular impact is, unfortunately, chronic excessive alcohol intake. Its effects on the liver alone paint a really clear picture of progressive cell injury and death, don't they?
Absolutely. The liver bears the brunt of chronic alcohol abuse. We see a spectrum of damage, often progressing through stages. First, fatty change, steatosis. As we mentioned, this is the initial, often reversible accumulation of triglycerides inside liver cells. The liver gets enlarged and yellow, often asymptomatic at this stage. Then, acute alcoholic hepatitis. With continued heavy drinking, you can get direct toxic injury. This causes hepatocyte swelling, necrosis, the appearance of those characteristic Mallory bodies we talked about, and significant inflammation with neutrophil infiltration. Patients can be quite sick with jaundice and liver failure. And finally, cirrhosis. This represents end-stage, irreversible scarring or fibrosis of the liver. The normal liver architecture is destroyed and replaced by fibrous bands surrounding regenerating nodules of hepatocytes. The liver becomes hard, shrunken, and functionally impaired. Cirrhosis is a very serious condition with major complications and often a fatal outcome.
It really illustrates that progression from reversible injury to irreversible damage and tissue remodeling. Okay, finally, let's connect all these cellular processes. ATP, depletion, membrane damage, cell death to the definition of death itself, and those classic post-mortem changes we learn about, like rigor mortis.
That's a great connection to make. Medically and legally, defining death is crucial. The Academy of Medical Royal Colleges in the UK, for instance, defines death as the irreversible loss of the capacity for consciousness, combined with the irreversible loss of the capacity to breathe. These are assessed through specific clinical tests. And one of the most recognized postmortem changes, rigor mortis, ties directly back to our discussion on ATP.
Right, so what does this all mean for rigor mortis? How exactly is ATP involved in that stiffness after death?
Well, after death, circulation stops. The body rapidly becomes hypoxic because there's no oxygen delivery. Mitochondrial ATP production ceases almost immediately. Muscle cells have some stored glycogen, which they can use for anaerobic ATP production via glycolysis for a short time, but those stores are quickly exhausted. Now, crucially, ATP is required not just for muscle contraction, but also for muscle relaxation. Specifically, ATP is needed to detach the myosin heads from the actin filaments in the muscle fibers, breaking the cross bridges. Without a continuous supply of ATP after death, these cross bridges remain locked. The muscles become fixed in a contracted state, leading to the characteristic stiffness of rigor mortis. It's a transient phenomenon, though. It typically starts within a few hours, peaks around 12 hours, and then gradually disappears over the next day or two as the muscle proteins themselves begin to decompose. The timing is influenced significantly by factors like ambient temperature and the person's condition before death. Understanding these changes, rigor mortis, algor mortis cooling, livor mortis, pooling of blood, is critical for forensic pathologists in estimating the time of death. And for all medical practitioners, understanding the underlying cessation of cellular function is key to confidently confirming death through those specific clinical assessments.
And that brings us, I think, to the end of our deep dive into cell injury and cell death. Wow. We've journeyed from the big picture of symptoms right down to the 4 pillars of cellular vulnerability. We've explored the 2 paths cells take when they die, necrosis and apoptosis. We identified those cellular smoke signals we can detect and cataloged the various kinds of clutter that can build up inside cells.
What's truly fascinating here, what I hope you take away is, well, how understanding these really fundamental mechanisms provides the language and the framework for thinking about almost every disease you will ever encounter. And this raises an important question for you, our listener, to ponder. As you continue on your medical journey, how will really understanding these smallest cellular details, the hypoxia, the ATP loss, the membrane damage, the apoptotic pathways, how will that impact your approach to diagnosing and managing the biggest, most complex clinical pictures you face?
Yeah, that's the real challenge, isn't it? So, next time you encounter a patient's symptom, will you not only trace it to an organ, but try to visualize the very cellular drama playing out within those tissues? Keep learning, keep connecting those dots, and we'll see you on the next deep dive.